Intraperitoneal TB, a danger lurking in the dark. Mycobacterium tuberculosis can affect multiple organs, most commonly the lungs. Rarely, TB may present with ascites, colitis, and abdominal pain by involvement of the GI tract and peritoneum, which is particularly difficult to diagnose. In the year 2017, there were 118 cases of TB involving the peritoneum in the US. A 37-year-old male from Central America presented with 3 months of poor appetite, abdominal pain, weight loss, and 4 days of fever. He denied dyspnea, but endorsed a week-long cough. He had a temperature of 101.2 and a heart rate of 114. He denied IV drug use, prior STIs, and was monogamous with his wife of several years. On his physical exam, he was in no apparent distress, although chronically ill-appearing, cachectic, with a protuberant abdomen and a mildly tender left lower quadrant. Subtle ascites was appreciated. Laboratory studies showed normocytic anemia, an absence of leukocytosis, ESR of more than 130, CRP 187, LDH of 229, and hypoalbuminemia. A CT scan revealed moderate anasarca, peritoneal thickening and enhancement, extensive adenopathy, and ileitis, as well as a tree opacity of the right upper lung. Initially, the concern was for occult metastatic malignancy or tuberculosis. Blood cultures were negative. Paracentesis revealed cytology negative for malignant cells, adenosine deaminase of 10, LDH of 735, and a serum ascites albumin gradient of 0.8. TB PCR and AFB smear of the peritoneal fluid was negative, as was quantiferin gold. HIV antibody test was positive, with a notable CD4 count of 50. Furthermore, we were unable to induce a sputum despite repeated attempts to do so, and a bronchoscopy was not pursued as the primary symptoms were abdominal in nature. Instead, we directed our attention to the abdomen, and the patient underwent a colonoscopy that revealed ileal ulcerations with an omental biopsy notable for necrotic granuloma. Subsequently, peritoneal fluid culture confirmed the diagnosis of tuberculosis, and after discharge, both his omental biopsy and colonoscopy also revealed cultures growing TB. The patient was started on quadruple therapy for TB with HAART deferred until 2 weeks following antimycobacterial treatment. This case highlights the diagnostic difficulties of intraperitoneal TB and serves as an important reminder to always entertain this entity in view of epidemiologic and clinical findings as seen in our case. Intestinal tuberculosis may present similarly to other diseases such as inflammatory bowel disease and malignancies. The gold standard procedure is laparoscopy with a peritoneal biopsy for histologic and microbiologic confirmation. However, we must always consider less invasive procedures, balancing the risk of aerosolization when deciding on how to best obtain a sample for diagnosis. Given the presence of AIDS, the risk of malignancy, such as lymphoma, was heightened. Therefore, a conclusive diagnosis had to be pursued. Paracentesis, a CT-guided procedure, or, as in our case, colonoscopy, were and may be instrumental in order to confirm a patient's disease.